Welcome to the June 2022 edition of the ASC eJournal series. I'm Dr. Rezaei, the chair of the eJournal committee. I'm also the co-presenter of today's talk, but will be mostly moderating the session. The credit goes to Dr. Ali, who did the work and now will be presenting. I start with a brief introduction of our panel. And Dr. Ali is a member of the eJournal committee and will be the presenter. She is currently an associate professor of pathology at Wake Forest University in Winston-Salem, North Carolina, where she is also the director of cytopathology. I have to say that I have had the pleasure of knowing and working with Dr. Ali as a cytopathology fellow at the George Washington University in my previous years. We are also very grateful to have with us the author of the paper to be presented today. For those of you who joined us last night in our Twitter chat, you already know Dr. Vanda Torous. She is a cytopathologist and surgical pathologist at Massachusetts General Hospital in Boston, where she is the director of cytopathology QA/QI program and the cytopathology fellowship program director. In addition, she is currently a member of several ASD committees, including Clinical Practice Committee, Program Director Committee, and not to forget the Art for Advocacy Committee. Thank you so much for making the time in your very, very busy schedule to join us. As a reminder, this session is live for the audience, and we encourage our audience to engage in our QA portion by posting your questions in the question box. I will be monitoring it, and we generally dedicate the last 10 minutes of the talk to answer your questions. With that, I will pass the virtual podium to Dr. Ali.
Thank you, Dr. Rezaei, for that introduction, and thank you, Dr. Torous, for making the time to be here from your busy schedule. I also want to thank the committee members of eJournal for their dedication and support of this forum. So we'll start off, and just so I can move on to the next slide. Dr. Kati Rezaei, as she said, is the co-presenter, and she did as much work as I did, and I'm very grateful to her for manning the Twitter chatter yesterday. And I have had the pleasure of having her as an attending when I was a cytopathology fellow, and she was spectacular. And without further ado, we have both no interests of conflict of interest to declare. So I'll move on to the learning objectives for this presentation, and it is threefold. It is to attempt to answer the following questions. Is volume of pleural effusions a criteria for adequacy in diagnosis of malignancy? Are there any other criteria of adequacy in diagnosis of malignant pleural effusions? And finally, what are the sensitivity and specificity of diagnosis of malignancy in pleural effusions? So this is how the format of the presentation is going to flow like. I'm going to briefly review the mechanisms of pleural effusion formation, with particular emphasis in case of malignancy. I'm going to set out the historical context of studies preceding those by Dr. Torous, which set off the premise and the questions to her particular study. So I will present, after the review of the historical context, the study and the results of Dr. Torous's article. I'll then circle back and review the stated objectives in an attempt to answer those questions, and then we'll open up the discussion to the audience online. So firstly, the mechanism of formation of pleural effusion is generally that the effusion is a result of a balance between capillary permeability, flow pressures, and osmotic pressures. In particular to malignant pleural effusions, these factors are all implicated when there is physical evidence of tumor implants in the pleura. So you can get increased capillary permeability, you can get increase in pre-capillary hydrostatic pressure, and you can also get increase in osmotic pressures outside the capillary bed, all of which will result in more fluid in the interstitium or accumulation of pleural fluid. But you can also get a impaired lymphatic drainage due to lymph node metastasis. For example, a lymph node that's overrun by squamous cell carcinoma will block lymphatic drainage and will result in fluid in the pleural cavity. Similarly, bronchial obstruction by central tumors like squamous cell carcinoma or small cell carcinoma will result in increased hydrostatic pressures and may also decrease lymphatic flow back centrally and will result in pleural effusions. Tumor microemboli in vessels and in lymphatics will also result in changes in drainage and in hydrostatic pressures. So mainly the important takeaway from this is that the malignancy does not have to be physically present in the pleural space for there to be a pleural effusion. So moving on to the historical context of the study that we're going to be discussing, these are five studies that precede Dr. Toros's article. And the ones that are highlighted in red are the ones that are prospective in nature. The other three are all retrospective. So we'll start off with a study by Salah et al., which was in 2002. And they wanted to look at the volume of pleural fluid required for diagnosis of pleural malignancy. Their study question was, what volume of pleural fluid should be extracted from a patient to optimize the diagnostic cytologic yield? And their study was a retrospective study. It had 282 patients, resulting in 374 specimens. And the cytology was using cytospins and cell blocks. The cytology was reported as positive, negative, or abnormal. And in the final analysis, they did a binary analysis using the positive for malignancy versus the negative, with the negative bin including the abnormal bin, which is probably one of my biggest criticism of this study. The samples they received were grouped into 4 bins, so quartiles. They were less than 10 mils, 15 to 80 mils, so quite a big range, 100 to 775 mils, and more than 800 mils. And the rationale for doing this sort of quartile binning was that each group contained about equal number of specimens, or about 90 to 120 in each bin. They did a follow-up of 6 months using the cytology and pleural biopsy from their pathology database. So the results of their study was that the prevalence of malignancy in their population was about 35%. The range of volumes that they had was between 0.2 mils to 2.8 liters. And they calculated their sensitivity at about 56% and negative predictive value of 80%, which is pretty good for the performance of the test. They found that there was no significant difference in diagnosis, in the sensitivity or negative predictive value between any of the 2 bins that they had. But they did see trends whereby there was increased sensitivity with increased volumes of submission, and decreased negative predictive value with increased amount of fluid. But these are not these were not significant. So they concluded that the diagnosis of malignancy is not dependent on the volume of pleural fluid sample, or if you say it in another way, small volumes of pleural fluid can be used to accurately diagnose malignancies with the same sensitivity or statistical accuracy as larger volumes. So this was the result that they had. But again, the criticism is that they saw these trends, but they could not find a significance. And I think we cannot exclude the fact that they binned the abnormal results along with the negative results in their analysis. So the next study was a prospective study, and this was by Abu Zaib. And their study question was very simple. It was to define the volume of pleural fluid adequate for maximum yield of cytologic diagnosis. And their study design included 44 patients, and they extracted 50 mils of pleural fluid, and then they extracted the rest. And then they looked at the diagnosis of these two to see whether they concorded or did not. They used thin preps and cell blocks for their cytology, and they reported the results in a binary way, is positive or negative. And this was a blinded study. There was no follow-up because the study design didn't require it. Basically, they were just looking at the fluid at 50 mils and the rest. So the results was that their volume of effusion range between 250 mils and 1.8 liters, with an average effusion being quite large at 890 mils. The prevalence of malignancy was pretty high. It was 70% of the population had a malignancy. And the calculated sensitivity was about 74%, which is expected in such a high prevalence of malignancy. The negative predictive value is not relevant here because they did not follow up this question. They did not follow up these patients because the study design didn't require it. And they found 100% concordance between 50 mils that was extracted and anything that was residual to that. So they concluded that 50 mils of pleural effusion does not increase the diagnostic yield. So you can take 50 mils and leave the rest, and you will get the same result as if you took the entire volume. So then came another prospective study by Swideric, and their aim was to determine the volume of pleural fluid required to diagnose malignancy. And they improved on the previous study by Abu Zaib because they said, okay, so 50 mils is good enough, but is 10 mils better? Or is it as good as 50 mils? So they looked at 121 samples and they collected the fluid in aliquots of 10 mils, 60 mils. I don't know why 60 mils and not 50 mils, but that's besides the point. And then 150 mils. Their preparations were a direct smear, a cytospin, and a cell block, so very reasonable. The cytopathologist, again, just reported in a binary way, in a blinded fashion, either positive or negative. And their follow-up was for 6 months using their pathology database. And their results were that the prevalence of malignancy was 74%. So very like the study, the prospective study by Abu Zaib, pretty high prevalence rate. And when they looked at the cytology alone, they saw that there was an increased sensitivity and negative predictive value for 60 and 150 mils compared to 10 mils, which means that 10 mils did not perform as well as the 60 and 150 mils. However, when they added in a cell block, they found that the increased sensitivity and negative predictive value for 150 mils was more significant than the 10 mils. I'll say this again. So when they added in the cell block, the 60 mils and 150 mils behaved better together as a group. There was no difference. And the only difference was that the 10 mils fell out as really pretty low performing. So they concluded that the sensitivity for diagnosis of pleural malignancy is dependent on volume of pleural fluid, and that 10 mils does not perform as well as larger volumes. I'm sorry, and hence they recommended 50 to 60 mils of fluid for analysis for malignancy. So across the pond in United Kingdom, Scotland, Thomas also did a retrospective study to examine the same question of adequacy of volume in diagnosis of malignancy. And they really wanted a robust guideline for clinicians to advise them on what was the required volume to submit. So that was their question. They looked at this retrospective study. They looked at 2,155 specimens, and they separated them in 5 mils graduated volumes. The preparations were cytospins or smears in a cell block, and their category of reporting was the similar category that has been proposed by the International Forum for Reporting Serous Fluids. And their follow-up was with cytology and pleural biopsy, but the paper doesn't say for how long they followed up. So the results of their study was that the prevalence of malignancy in their population was 21%. So again, very, very different from the 74% that we saw in the prospective studies. And that when they looked at the rate of malignancies, they saw that it plateaued out at 25 mils, after which there was no additional yield of diagnosis. For fluid volumes under 25 mils, the false negative rate was twice that of those over 25 mils. So very significant if you went below 25 mils. So the conclusion was that they recommended sending between 25 mils and 50 mils of pleural fluid for cytological examination. Another retrospective study, which was the largest so far, was published by Rupert from Johns Hopkins. And their question was that what was the minimal volume of pleural fluid necessary for optimal cytological diagnosis? So they weren't just looking at the volume, but actually the diagnosis and how optimal it could be depending on volume. And they set out this study because there was conflicting previous studies, as we have seen, limited by sample size and or narrow volume ranges. So they did a retrospective study of the largest so far, 2,540 specimens over a 10-year period. And their specimens were, cytology specimens were cytospin and cell blocks. And they had 4 cytology reporting groups. I think the suspicious was just not included in this. So they probably just bin them with the malignant. And they had 9 volume groups. So they split them quite finely. There were groups that were less than 5 to 10 mils, 10 to 25 mils, 25 to 50, 50 to 75 mils, 75 to 300 mils, and then other groups up to more than 900 mils. Their follow-up was using pleural biopsy, which were obtained within 6 months. That's how they followed up their patients or their specimens. The prevalence of malignancy was very much like the study by Thomas from United Kingdom, with a malignancy prevalence of 20%, and their volume ranges from 2 mils to 6 liters, so pretty wide volume range. And they don't give data on sensitivity and negative predictive value across these volumes. So their results was that there was significant correlation between cancer type and specimen volume. So this was probably one of the first papers to show this connection. Also that malignant effusions had significantly higher volumes. So this had been shown before, but here you also confirm that the bigger the effusion, the chances are that it is malignant. The malignancy fraction increased from 10% in the less than 5 mil group to 23% in the 50 to 75 mils group, and to 20% in the more than 75 mils group. So basically what this tells us is that in smaller volumes, there was less rate of malignancy than the higher volumes. And when they did quite a nice statistical analysis called the Sizer analysis for volume trends, they found that there was a 75 mil cutoff above which there was no more yield for malignancy. But that the fraction of definitive cytological diagnosis increased even beyond the 75 mils. So they could come to a good definitive category of a cytological category, the more fluid that the specimen had. So they concluded that the fluid volume of at least 75 mils was required to eliminate the effect of volume on diagnostic adequacy, and that higher volumes correlated with decrease in non-diagnostic and atypical results. So now we come to the present study by Dr. Torous. And just to summarize from the previous studies, is that we had studies that stated 10 mils, even less than 10 mils. Any volume was good enough to diagnose malignancy. Then we had another study that said anything that was below 10 mils was not very good. And then we had another study that said anything below 25 mils was no good. And then the last one that said 75 mils is really the minimum for adequacy. So Dr. Torous' study takes into account how much is now enough. And the study question is basically to examine the performance of low volume samples as part of ongoing quality assurance, and to actually look to see if a negative finding from low volume sample is reliable. And I think those are questions that we all struggle with when we go through our specimens, especially when they're low volume. Is a negative finding a reliable finding? So the study is a retrospective 1-year review of 226 samples with at least 6 months follow-up. And the follow-up here was done not just using lab data, which was what all the previous studies did, but actually looking at clinical data as well. The reporting of the cytology was using the 5-tier cytology diagnosis that is familiar to all of us. And the specimen categories that they had were less than 10 mils, so on the low volume side, 11 to 25, 26 to 50, and then more than 50 mils. So this was a study that really concentrated on the lower side of the specimen sample. The results were as follows. For the average volume was 446 mils with a median of 100 mils. So 14% of the specimens were less than 10 mils with a median of 2 mils. So again, this study is really towards the lower range of volumes submitted. 6.6% of the specimens were between 11 to 25 mils, and then about 60% of specimens were more than 50 mils. And the prevalence of malignancy in the population that they sampled was 24.4%. So in this bar chart, you will see that in the low volume side, the prevalence of malignancy is really much smaller than in the higher volume side, as you can see here. And this was significantly different. There was a difference between the very low volume and the higher volume in the rate of malignancy. Now, if you cut through here and class the under 25s and above the 25s, you can see that we're beginning to equalize somewhat. So here, when you look at volumes under 50 and over 50, you see that there is no difference in the rate of malignancy. So looking at their follow-up data, you will see that a third of their specimens, about 38% overall, had repeat fluids, and 24% were biopsied. And these were distributed equally between the very low volume sample and the higher volume sample, about 37.5% and 39.4% here. Pleural biopsy, 9.4% and 9.5%, so very similar in distribution of follow-up. And then in the follow-up fluid, this is pretty interesting. The number that was upgraded is nothing, 0% in the very low. However, in the more than 50 ml sample, the number that was upgraded on the follow-up fluid was, in this case, 0.7%, and then downgraded, which was very amazing, was 3.6%. Most of the downgrades occurred because of atypical diagnosis, but there was one suspicious diagnosis that was really revved up mesothelial cells due to treatment effects. And when you look at the pleural biopsies, the ones that were positive in this category were all from squamous cell carcinomas. So these were the ones that were the sample was negative, but the pleural biopsy was positive, and those positive pleural biopsies were squamous cell carcinomas. So the study actually quotes the limitations in that there were low case numbers, but then over a year, I think that was a very reasonable study. The sample processed was relative to the total aspirated is not known. The author says that you receive 5 mils, for example, but you don't know whether 5 mils is actually the total sample is what they chose to give you and threw away the rest or submitted it for some other studies. And that additional studies to determine the specific effect of cell blocks on adequacy for low volume samples would be needed. Because as you can imagine, if you have a low volume sample, you're probably not going to get a great cell block, if at all. So the conclusions of Dr. Torous' study was that very low volume samples were significantly less likely to be positive for malignant cells. But they were not more likely to have an upgrade on follow-up fluid sample. That is, it is a reliable diagnosis when you say it's negative on a low volume sample. But this is on their population in their study. If, however, if you have a high context of clinical suspicion, for example, those cases that had squamous cell carcinomas metastatic to the pleura or involving the pleura, and you had negative pleural fluid, then you should probably put an adequacy comment for the low volume samples. So in summary, there are potential confounding factors in analyzing pleural fluid for malignancy, depending on the prevalence of malignancy of your study population. For those study populations that had a very high prevalence, you could find malignancy in very low volumes of fluid. Studies also that did not, you cannot control basically these studies for the total amount of extracted fluids. The prospective studies could, and they found very similar results in that even 10 mils would work. But we cannot do those studies as part of a QA because we do not know generally how much was extracted and how much we were given to look at. There is a question about variability in preparation, especially in cell blocking, and how people in their own labs triage cell blocking, whether it's done up front on any volume or it's done at the discretion of the reporting cytopathologist or at the discretion of the cytotech. And obviously we saw that the type of malignancy influences whether a pleural effusion, whether malignancy is going to be seen in pleural effusion. And the really significant example here is that squamous cell carcinomas do not tend to involve or shed into the pleural fluid. You may see them in the biopsy of the pleural itself, but you are unlikely to see squamous cell carcinoma in the pleural fluid, even though it is a malignant process of formation. So we'll go back to review the objectives of the of this presentation. Is volume of pleural effusion a criteria for adequacy in diagnosis of malignancy? Well, in my opinion, it may be, but it's absolutely not the only factor involved. Are there any other criteria of adequacy in diagnosis of pleural effusion malignancy? And yes, clinical suspicion of malignancy increases your chances of seeing a tumor cells, but it also depends on the type of malignancy that you have. A squamous cell is not likely to shed into pleural fluid in spite of the volumes that you might have. Which brings me to the last, I'm sorry, to the last question. What are the sensitivity and specificity of diagnosis of malignancy? Well, that very much depends on your population. And if you are in a prevalence of 74%, as we've seen in some studies, then the likelihood is, yes, you will see malignancy in very small amounts of fluid. But in general, the sensitivity is about 40 to 80%, and the 80% is when you get repeated submissions for pleural fluids. So by the time you get about 3 of them, you are up to about 80% sensitivity for diagnosis if the malignancy is in the pleural fluid. But the specificity is more than 90%, and in Dr. Torous' study, it was 100% basically. So that's all I have, and so I'll open up to whatever questions the audience might have. And thank you once again for attending and for listening to the webinar.
Thank you very much, Dr. Ali. That was very thorough and very well put together. And I guess we have Dr. Torous with us, and we would like to ask if she has any, any words of wisdom after what all we have done.
Hi, thanks again for having me. I really appreciate it. I think this was a wonderful discussion and presentation, and really went through, I thought also a great review of the literature, but I think really hit on the important points. And I'll start by saying, like you had mentioned, I'm the director of QA/QI cytopathology here at MGH. And this really was like a real world sort of issue or problem that had arisen, because, you know, it's not uncommon for us to receive low volume specimens, and on top of that, very low volume specimens. So, you know, it's great to have these recommendations that we have, you know, 50 to 75 milliliters sent to us for optimal sort of evaluation. But what happens when we don't get that optimal volume? You know, how accurate is that? And, you know, so again, this was like a real life issue that I was interested in. And the results were pretty surprising to me as well, really showing that there wasn't really significantly more follow-ups that were positive in cases that had very low or low volumes. And I think that really goes to, you know, this study looked into the history and clinical setting of these samples. And so my suspicion is a lot of these ones that are add-ons probably just had low clinical suspicion for malignancy to begin with. Maybe the sample got sent preferentially or was prioritized for microbiology testing, right? So it's like you know, they were wondering, is it infectious, this or that? So anyways, I think, yeah, the question of what is adequate may seem simple on surface value, but I think that it really is a complex question. So I liked how the answer was, you know, to is volume important, and it maybe is. I mean, I do think that it's important for a number of reasons. For instance, you know, being able to get a substrate for ancillary testing. If we have very low volumes, that really limits us to be able to do that. So that is a very important and, you know, vital factor to consider as well. But yeah, I just think that the question in general is probably more complicated, or is more complicated than what we think on face value, perhaps.
Very good. Couldn't agree with you more. Like most questions, they're not simple answers for them. We did not have a question yet, but we had a very positive feedback from our past president, Dr. Barkan, who said excellent review. So, so this was very nice, actually, nicely done, and I would second that as well. So let's see. Okay. At Wake Forest Baptist, we found that 30 ml is ideal, but we may use more if available. This is based on cell block cellularity. Okay. I guess I can definitely agree with that yes, it is good, but at the same time, I know that where I am before and even now, we always do cell block. I know that at Mass General, and we talked about it last night in Twitter chat, and in your article also, it says that you guys preferentially make cell block. So it's at the discretion after initial review. So, and the other thing is that definitely, I mean, we talk about volume by itself, but it's actually the cellularity that makes or breaks the deal. And we have no way of knowing before we kind of look at the fluid. Sometimes you have floating pieces in there, so that's kind of a giveaway, but that doesn't necessarily mean they're malignancy. But that's basically, I kind of agree, and I think the 30 ml ideal, probably, but as you said, even sometimes 10 ml gives you the answer, depending on the process that give rise to the pleural fluid, and also the fact that how much cells shed in there. Those are all the things that would make it or break it. And at the same time, in cytology, we never say insufficient to things that have even a touch of atypia in something. We do that with everything else that we have adequacy criteria for. If you have atypia that is suspicious for being something more than just, oh, well, it's a reactive atypia or something like that, you kind of raise that, you flag that case. You just don't put it in the basket of insufficient or inadequate.
Right.
But having said that, I think we all kind of learned from it, but I will ask you guys to also comment on that question. I just took the took the initial on that.
Yeah, I mean, like we were saying, I just think there's so many different factors, and cellularity is a big one in of itself as well. And you never know based off of the volume itself what the cellularity is going to be. And that gets into another question of adequacy, because we have cellular criteria for other sites, such as the cervix, cervical pathology, cytopathology, as well as thyroid. But we really don't have the same for fluids, right? Because it's not by number of mesothelial cells or histiocytes or anything like that. It's based on the underlying process and a number of different things. So it is quite complex.
Right. No, absolutely. I have a good question, actually. How much fluid do you concentrate if you receive 1,000 ml of fluid?
So we will, I have to think back, we will actually, I think, attempt to do all the fluid, even when it's in large volumes. And they'll basically spin it down in, I want to say 50 ml increments, but they do try to do the whole volume.
Yeah, that's what we used to do as well. Right now where I am, majority of times we don't get the entire volume, and that has to do with the notion that, as a reference lab and specimens come from all around the country. So they don't necessarily send you 1,000 ml. I think that the logistics of doing that is very tough. So we don't receive all of the volume. And but when I used to get that, I would actually encourage our colleagues to send everything to us. Let us be the holder of the tissue or the fluid, rather than them deciding how much they will send down or not. It was easy in a hospital setting because they're right there and they just bring it down, from the OR or from the.
Yes. I think once you homogenize the whatever volume you get, once you homogenize it, I think then you can sort of say, well, I'll take 50 or 2 cupfuls and spin those down. But I think in terms of cost and time, and looking at a liter is pretty time consuming.
Right, like processing it is very time consuming. I agree with you. So that's that. So let's see the next question. Has anyone looked at mesothelioma versus metastatic, and which makes more fluid?
Yeah.
So, I actually had that question, sorry, before you answer. Any of the studies that you have provided, including your study, were there mesotheliomas in the batch of your malignant ones?
In my study, I believe there was at least one. I forgot the exact numbers, but I did have documented in a table what the tumor types were for the ones that we had results on. I believe there was at least one mesothelioma case.
Right. But now,
or at least
I'll let you guys to answer the question.
I don't recall any studies looking at exactly how much volume and dividing it by tumor type, but I'm sure that it probably is reliant to some degree, because as we know, or at least what is yielded, because as we know, some tumors, for instance, squamous cell carcinomas may metastasize to the pleura, and pretty often, however, they just don't shed into the fluid. So I think, regardless so much of like how much volume it may cause, the tumor type is important, and that goes into sort of the biology and pathogens behind a lot of this, I think.
And I think I read some material about mesotheliomas, and generally because they don't tend to accumulate fluid, they're more like, they encase rather than accumulate fluid. But when they do accumulate fluid, it is the epithelioid type. The sarcomatous hardly ever does. So, and because their prevalence is pretty low in the population and in studies, it hasn't been specifically looked at in terms of volumes. And when you look at the type of malignancies that go to the pleura, that the biggest study I think by Rupert did, I'm not quite sure if mesothelioma made it in the most prevalent. So I think it's pretty low down, if any.
Very good. The next question, what about using a footnote or comment on fluid reports instead of true adequacy?
I'm sorry, can you repeat that question?
Sure. What about using a footnote or comment on fluid reports instead of true adequacy?
So I've started doing sort of both, where I'll put in the adequacy, limited by low volume. And this is for like very low volume specimens. But I also have a comment that I put as well. And usually I'll put that comment A for very low volume specimens, as well as, if they have some sort of clinical suspicion for malignancy, then I'll add that. And I do that for a number of different reasons. One, it's particularly if it's a negative, fluid, to let them know perhaps this is not representative, right? So if they have a high clinical suspicion and the fluid reaccumulates, then to send additional sample for cytologic evaluation because it may yield something else. The other reason for putting a comment is perhaps alerting clinicians that, the ideal fluid volume is, 50 or 75 or higher for samples. So, getting the word out that higher volumes are ideal, I think is helpful. So adding a comment, I think, is helpful for a number of different reasons.
What do you do, Dr. Rezaei, at your institute?
At the current time, I actually, because as I said, we don't necessarily get the entire fluid. So I try to give some sort of a feedback. And again, I will figure out if there was more fluid, especially in the cases that I'm not necessarily happy about calling it negative. Because I see the same patient, for example, having 5 fluids over time that we have called atypical, we have called this and that. So those I reach out and figure out for the most part. But at the same time, I will put a note in there that, given the prior diagnosis, given this and that, given the suspicion, because these patients generally, they do have something, if I get that history, I would say the fact that this is negative, especially if I have a scant cellularity, I would say this begs the question: do I have enough optimal volume or optimal material to assess it? So it's always a matter of kind of conveying your concern to your clinicians, because hopefully they read the notes and the comments. So that would probably be the way that I do it. I don't have necessarily a set number to say, oh, I only have this ml, and then I will. That would trigger me to do that. Maybe I should, because maybe it gets people who are sending very little when they have more. Not 1,000, because we can't handle that as far as the transport over here, but that may be helpful. We have plenty of questions. Let me just go to make sure that we don't. Do you recommend additional cell blocks with clinically suspicious cases? For some cases, I find the tumor cells with 1 or 2 additional cell blocks. I would say yes, I guess, especially if you, on your first attempt, you're kind of getting some things, but you're not there to call it. I would say yes, but I will let others to chime in.
No, I agree with you.
Very good. What about you, Dr. Torous?
Yeah, so like you were mentioning, for our institution, we perform them, once there's been an initial cytologic evaluation, though based off of the clinical history, we may do a few of them up front. But yeah, I mean, if you're seeing something and you think maybe doing another one might be helpful, it doesn't really hurt to attempt to do another one, especially if for some reason you think maybe something failed about the first time or something like that.
Right.
It doesn't hurt to do.
It's analogous of getting deeper levels on the cases that you keep looking at it, and then you said, I really think I need deeper level. So I would say it's the analogous of that. I think we already answered this question, do you spin all the volume in increments? So yes and no at the same time, and we realize that it's a lot of extra work and maybe not yielding much. So I guess in your institution, depending on how much volume you get on your fluids, you may want to devise a way to do it. If everything that you get is like 2000 ml or 1000 ml, you may want to consider, coming up with a thing. But if it's once in a while that you get those, again, we all have different, I don't think there is a right or wrong answer for that, but I guess that's that. If you receive chunks of tissue floating, do you pick up and process instead of them, process them instead cell blocks, or you do both?
For fluid specifically, or?
I guess that's because, yeah, floating in a fluid, I'm assuming that's what it is.
I think we probably, for other I'm not sure for fluid specifically how often that happens, or how often we do it.
I have to say, my thing was that if you see real fragments, not just cloth, because cloth in the pleural fluids or fluids in general, you get a lot of things that kind of are floating, but they're just fibrin and something else with it. So those probably, once you spin them down, they do not stay to be fragments. But if you end up with real hardy fragments, I used to tell them to pick them up and put them, through, and then also do your process for the cell block, just to increase my chances of getting as much cells as I can in whatever I have. I don't know if there is any let's see. The question is that the utility of sample volume has it been correlated with performing ancillary testing like NGS for lung carcinoma?
This came up yesterday as well during the Cyto chat. I mean, I'm unaware of looking specifically at volume for these, but I would imagine that it plays a factor. But again, it's probably a much more complex question than just volume alone, I would imagine.
So with the advent of liquid-based analysis, this is going to be more and more important, that we probably will refine our volumes, but it will be more towards the very, very small volume now. Because using the liquid-based analysis for tumor, you can find, I'm sure, if you have a tumor nearby, you will find DNA within the material, and they can fish that out. But that will be less about cytology and more about molecular testing.
Right, which is nowadays is really the end point of many things that we do because of the prognostic markers and everything else. But at the same time, it has to do with how much cells you capture, unless you're talking about cell-free analysis, which is a totally different animal altogether. Yeah, right. So yeah, so I guess that's I guess we'll see. We shall see in the future that is coming. Another question about when they get 20 to 30 ml and they're asked for a lot of ancillary studies, they hardly get cells to be able to do all of satisfactory results. And I think that goes back again. I'm not sure necessarily if those cases may have given you more if you had a whole lot more. Again, the question is that the nature of the disease, how many cells it shed, and how much of that you have. Sometimes you have a lot of cells, but most of them are dead and they're not viable, so you can't evaluate a lot of things that you would normally need a viable cell, like for example PD-L1. I'm looking at PD-L1s in cell blocks, and I have to tell you it's very tough. I do not take them lightly, because then you have so many other things that pick up PD-L1, and then you're trying to sift through to see what's what. So it is hard. So I guess my only thing is that when you get a case and you're looking at it like everything else, when we get a small biopsy, when we get a cytology sample, when you have to do ancillary stuff, prioritize, because you know that many times by the time you get to the end of your list, the cells are not there anymore. So have a strategy to prioritize and kind of when I'm looking at the molecular, or when I'm looking at the biomarkers for prognosis and for treatment and all of that, I always look at what is available for targeting if I have something. So I start with that, because the other stuff, they may be good to know, but at the current time, we don't have a target for them. So even though it's good to do them, and we do them as a standard panel, but if I have only this much, I will do it for things that I have a target for, and hope for the best, I guess. So let's see. So, very nice. We also have another very good comment. A great job, everyone. Interesting discussion of a real world question, Dr. Pittman. So that's very good. Thank you very much. Very good. How do you handle, well, I guess we talked about the molecular testing requests. How do you assess adequacy for cellularity? I guess, again, I don't know of any set number of cells that you have. I know that, for example, when I'm trying to do, again, PDL1, for example, I keep saying it because I am on the IH evaluation this week. So I do look at a lot of PDL1s. So you do start with, do I have viable cells? How many viable cells? That you start with like 100 viable cells, and you kind of go from there. If I have not that many, I still look at my PDL1. If it's coming back as positive, then I will kind of put it aside. If it comes back and I have low number of cells but it's negative, I always put a comment that it is negative, but you have to interpret this with caution because the number of cells that I had to evaluate was low. If it is very low, then I would say it's insufficient, because you can't give a percentage when you kind of have only like what 10 cells to kind of give the diagnosis of. So I guess I don't know if anybody has a better answer, but that's what I would.
Yeah, I think that's fair comment. It's hard sometimes to evaluate whether you've got enough for the test or not.
Right. I think we answered, whoever asked the question had answered yourself. Can you charge for extra cell blocks? The answer is no. No, we cannot. It's one container, one thing, and we do the cell block off of it. So however many you do, it's just making levels on things. Or when even from the same container, when we make so many sections of the same tumor, for example, we don't. Unfortunately, it would have been great, but no, we don't. So I guess you got the answer right. Yes, for fluids, we get it quite often. What does that mean? I'm not sure. Yes, for fluids. So in fluids, if you do the same container and do more cell blocks, you get to charge them. I'm not sure. Because I'm under the impression that if you have one container that comes, no matter what you do with that container, you have one charge for no matter how many smears you make, how many cell blocks you make, how many thin preps you make. The immunos and special studies are different because those you do it based on however many you needed. But okay, I guess good to know. Thank you. I don't charge, but my colleagues argue sometimes. That would be probably a good question to ask a CAP committee, because again, I don't, honest to God, I don't think that we ever did, and I don't think you can, but please let me know and we'll see. I think there would be a lot of happy people if that were the case, but I seriously don't think so. If you have left and right pleural fluid, yes, obviously you have two different samples. If you have pleural fluid number 1 and pleural fluid number 2, again, they're coming at different samples, but I do not think so. All right. I guess we ran through our questions and hopefully we answered the questions. Thank you so much for your presentation, your work, and your willingness to join us when we were discussing your work. Thank you for the audience to have been very engaged, and the same way that last night it was very nice. We had a lot of audience engagement and participation. Thanks to our presidents, ex-presidents, and current presidents for joining and giving us very good feedback. And I think if there is nothing else, we can say goodbye, I guess. We are about an hour. We started a little bit later. Just for the audience, whoever is still on, just to make sure that there will be questions for your CMEs that we will put out, not right now, but in the next week, there will be those questions that you can, look at them, answer them, and get your CMEs for attending. Any last minute? No?
Thank you so much. Thank you, Dr. Rezaei. Thank you, Dr. Torous. And I'll sign out.
Very good. Thank you very much. Have a good afternoon. Bye-bye.
Bye.